got a code brown. Welcome to Bedpan Banter. With me, Nurse Mike, the daddy of nursing. Can I get a bedpan over here? Welcome back to Bedpan Banter, the official podcast of Simple Nursing, where we talk about the human side of healthcare. I'm your host, Nurse Mike, and today we have a very special guest, Julie McFadden. You may know her as Hospice Nurse Julie, with over 4 million followers across your platform, and I think it's the first time we're ever interviewing a New York Times bestseller for her books.
Thanks for having me.
So you've been a nurse for over 17 years?
Yeah.
Wow. And you have most of your experience as an ICU nurse?
It's like half and half now.
Okay.
So yeah, ICU and then switch to hospice.
And how long have you been in hospice now?
Oh my gosh, I really need to figure it out. Probably 8 or 9 years.
Okay.
Yeah.
All right, so let's talk about your start in the ICU. Did you always know you wanted to do ICU, or was it?
No, I mean, I was young. I don't know about what your experience was. Like, I was young and full of ego, and I was like really excited about being a nurse and couldn't believe when I finally passed my NCLEX and all the things, right? And I remember Googling like #1 hospital in the country,
Whoa.
which was Johns Hopkins at the time.
Yeah.
And then I thought being an ICU nurse or an ER nurse were like the baddest, like the best thing to do. So I applied for ICU first, and I got that job at that hospital.
The first out of the gate job.
Yeah.
Wow.
Yeah. I mean, I feel like back then, I don't know, it seemed like it was easy to, like, nurses, I think nurses are always needed. I don't know.
Yeah, they're always needed, but I think there's certain time gaps.
Yeah. I mean,
Yeah.
17 years ago, it felt like easy to get a job. None of us were like, oh, I don't know if we'll get a job. We all were like,
and like all this stuff.
yeah. Yeah. So that was a long-winded, I didn't know what I wanted. I just wanted to be like the best.
Yeah. Was it CVICU or was it just ICU in general?
It was surgical ICU at first, and then eventually I went into like surgical trauma ICU at that same hospital.
Oh my God.
Yeah, so it was soul crushing.
Really?
Yeah, it was. No, I mean, I had a whole plan, right? After 2 years, I was going to go back to school for anesthesia.
Oh, CRNA, yeah.
Yeah. And then after 2 years, I was like, I don't know what I'm doing.
Yeah.
This is so, I'm still feel scared. I still feel new. And then even longer after that, I was like, I don't know if I like this.
What, like nursing in general?
Yeah, nursing in general.
What made you like really think, was it just your patient acuity? Was it patients that weren't getting better necessarily?
Yeah, I think, I mean, like my transition to hospice, because I think initially I was always afraid of like, quote unquote, like losing my skills, right? Like I didn't want to lose my skill. That's what I thought.
Yeah.
But in the ICU, I just wasn't, there were so many amazing things happening. So don't get me wrong. Like the ICU is a beautiful place. It saves many people's lives. It's wonderful. But to me, it always felt like I had to like hurry up, get a bunch of tasks done. Many of them are amazing. A lot of them felt like these like tasky,
Little punch on it.
Yeah. And it was always like we need you to care a lot.
Yeah.
But hurry up.
Yeah, hurry up, get this stuff done.
Hurry up and do it, and hurry up and care. And it was like, oh, I just felt so awful all the time. And then a lot of people were dying too. And then as I was doing this for a long period of time, I could tell that there were certain people that were really sick, but we knew they probably would get better, right? They'd get out of the ICU. They would live. We would help them survive. Then there were some that I felt like we kept alive, and we all knew we shouldn't be doing this. They're going to die. They're not going to get out of here. But we still did it. And we just weren't talking to the families about like the truth, the reality of what was happening.
Wow.
I don't think anyone was like purposely doing it. I think we all just had blinders on. It was like survival at all costs.
Yeah, just keep them alive.
Yeah.
On all the drips.
And
all
like
the tubes.
on all the drips, all the tubes, all the machines. And I think everyone was kind of like, someone else will make that decision on when enough is enough. Right? Like it was like passing the buck. Like the pulmonologist won't say it. The cardiologist won't say it. The intensivist, maybe they'll say it. Like maybe someone will eventually say to the family, like, enough is enough.
Yeah.
Have that hard talk.
As a nurse, like, does that all fall on you? Because you have to see the families a lot.
I didn't know who it was gonna fall on. That's what I don't know. I'm sure it's not always like this, right? And it might be even different now. And there were times when people would say the hard things, but most of the time they weren't. And that after years of doing that, I was like, someone has to. And I eventually got confident enough to be the person who would raise my hand during rounds and say,
what are we doing? Yeah.
What are we doing? Yeah. I mean, I would say like, can we get a family meeting together? Right. And of course, everyone kind of knew what that meant. And what I saw was they listened. right? And we would have these family meetings, and then we would talk about what was happening. And then the patient would die. We'd take them off the machines. We'd take them off medications, because once the family heard the truth,
Yeah.
they were like, my loved one wouldn't want to live like this.
Mm-hmm.
And so those experiences in the ICU was what made me start thinking like, okay, I'm not really happy here, but where else would I be happy? Like and hospice was something I thought about, because I was like, we're all going to die.
Yeah.
And that's the truth. And if we are, like, there has to be a better way to do it than like what I'm providing here.
Yeah,
You
there
know
should be
what
like
I
a
mean?
best practice
Yeah.
on the exit, because there's best practices on the entrance, right? We have all the
Yes.
APGAR scores and yada yada
Yes.
for the babies, but yeah, you're right. There's not really a cohesive developed plan that's evidence based. That's like, and thank you for
There we go.
spearheading the way
Yeah.
on this.
Yeah, and that's how I transitioned to a hospice nurse, and it still took me a bunch of years even after that realization, because I was afraid to leave I was used to being an ICU nurse. So I was afraid to leave. So it's still, even after that realization, it took me a long time, but I eventually just took the plunge and became a hospice nurse.
You were already a hospice nurse, kind of, in a sense,
True,
right?
Yeah.
Like a good portion of your job as an ICU nurse, you had those patient populations that were going to die anyways. So
Yeah.
would you say like the big difference in those scenarios is communication and educating people? Because sometimes they don't want to hear it, right? I guess. Or...
Yeah, I mean, I think communication, there is a huge difference with dying in the ICU and dying on hospice.
Oh, okay.
Huge difference.
Okay, explain like
Very, 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 very different.
Okay. Oh, yeah.
So in the ICU, it's usually like they've already been kept alive for quite a long time. So there's a lot of issues there. They're on a bunch of machines and medications. So by the time you take them off of those things, they're dying usually very quickly.
Oh, man.
Right. So it's
a
like,
matter of hours, yeah.
which is like fun, which is okay. I mean, they look different because they've already been pumped full of fluid. They've already been in a hospital bed for 6 months. They've already have necrotic toes and necrotic fingers and necrotic noses sometimes.
Oh my.
And they're like, so they just look really different. They die quickly and comfortably, but it is quick.
Yeah.
And the biggest thing I noticed becoming a hospice nurse, which was mind blowing, hence why I did all this stuff, is that that's not how it happens when you die naturally. It takes a while, usually, if you don't come on hospice too late, and your body is built to die. And it helps dehydrate you. It helps put you to sleep. What? There are so many patients that I've never had to give, and I'm not anti-medication.
No, of course, yeah.
But there are so many patients that I didn't have to give any medication to because their body just like naturally dies. And not in pain. Like people always think dying is painful. But diseases you die from can cause pain, which is a symptom, right, of the disease. But dying itself, particularly if you're dying what I would call a natural death, which is like you're dying from something, but you're allowing the body to naturally
shut off the system,
shut off itself, is not painful.
Wow.
And I know, exactly. Like I didn't, even as an ICU nurse, I did not know this. So to see it was like that first year of hospice nursing, my mind was blown over and over and over again by like the difference. And to me, it was so comforting to know like, wow, our bodies help us do this. Our bodies are literally built to die.
Yeah.
And if you allow it to happen, it can be like a very natural, like, dare I say, beautiful process.
Yeah. So that kind of segues or transitions into a lot of the summary that you put in your book between dying in the intensive care unit, which sounds intense, right? The entire body looks different, versus dying a natural death and a dignified death, or...
Yes. I mean, you said it perfect.
Yeah. To summarize this, I think it's all about therapeutic communications, what you're saying, and collaborative approach, because in the ICU, we want to keep people alive at all costs. And it's up to advocacy of nurses to stand up and, just like you did, bring all the providers and doctors and healthcare practitioners together. What do you think the best way to communicate that for nurses who might be intimidated in the ICU?
Well, so what I found was I was speaking the elephant in the room. Like I thought I would speak up and people would go, don't say stuff like that. We're supposed to keep people alive at all costs. And but that's not what anyone said. Everyone was like happy that someone brought it up. Right. And I think, again, I don't think I know no one is purposely not bringing it up, right? I think we all just have blinders on. And like you and I both know, in nursing school, I'm sure there was a part of nursing school about death and dying and how to talk to patients, but I don't remember it because it was very small.
I did a 5-minute video on it, that's all I'll say.
Yeah. So like, And same with medical school, I think. And then you get into the hospitals, we're not talking about it either. We're talking about like, what do you do when someone's blood pressure's low?
Right.
What do you do when someone is in respiratory distress? It's always about like the decision to keep them alive, right? So our brains don't go there. I never was chastised or like told not to do it when I brought it up in the ICU. And after a while, you can tell, you can see like, oof, this isn't looking good. You know. And everyone's thinking that. And no one just knows who's supposed to say it. So all I'm saying is I'm wanting to encourage people, whoever's watching, whether you're a doctor or a nurse or you can be the one. You can be the one to speak up for your patients. And it feels weird to advocate for your patient
dying,
death, right? And that first time I did it, and the first time I ever did it, and this is actually in my book. So the first time I ever like brought it up, the patient died before the end of my shift.
Wow.
And I remember going to my car and crying because I remember thinking like, because of me, it felt like because of me, this patient died.
It felt like your fault, yeah.
And of course, like I knew logically it's not my fault and it was the right thing to do. But it's just that first time you do it, it's a little bit like, oh, wow, I really had the power is what it felt like. I had the power to speak up, have this meeting. They heard the information and the family said, we're done.
Wow.
And so it was sad, but it also was like, oh, that's what advocating for your patients is. Because to me, death is not the worst possible outcome. Like suffering is far worse. And a lot of times we create a lot of suffering.
It's very true. Working in the ER, and a lot of our viewers are nursing students and aspiring to go to the ER, ICU, or new grad nurses or new nurses. And I think the most practical thing that you've explained in your book, and I even Bunny Ear did here, don't mind our little placeholder.
Yeah.
But I love this. It's so practical. It shows you the difference between what you're tempted to say, your internal thoughts, and what you should say for therapeutic communication. This is very practical. It's amazing.
So that is exactly why I wrote the book first, and then I would say like 6 months later, we started with the journal, and I was more excited about the journal because I'm a big practical girl, right? Like I want like, okay, we're supposed to be talking about it. Tell me exactly how.
Yeah, exactly.
Tell me what to say. Tell me what to do. So the journal was developed to help people like know where to start, know how to do it. And I think what I have found 9 times out of 10, maybe even 9.5 times out of 10, people are relieved that someone's willing to say the hard thing.
Oh, wow.
People are not like, don't say that. People are like, finally, someone's willing and not afraid to say, death, dying, dead. Here's how long we think your loved one has. The more, you can deliver it with kindness and compassion, but the more direct I am, the more relief I see on people's faces. Because people want, even if it is still an illusion, but like control. And they have more control when they know what the heck, can we swear?
Yeah, what the hell's going on?
Yeah, what the hell's going on? Right? What the hell's going on? And you'll learn over time. And you're going to mess up, right? You're going to mess up. You're going to get people who get mad at you sometimes. But it's like when you know what you're trying to do, when you know the reality of the situation, you'll get better and better at it as time goes on. So you just got to practice. You got to do it.
It's just like any skill, I guess. And
yeah.
And I think that's the hardest part about being a nurse is just knowing that you're not dumb. You're just new.
Yeah.
That's your first time doing stuff, and that's okay. There's always first timers, like even if you've been a nurse for a decade. So before we get into the book, let's talk about the journal. Who is the journal? Who was it written for? Was it written for the family, for the practitioner, for the nurses?
Of course I'm saying this, right? I want to say it's for everyone, right? But to me, it is for everyone. The book and the journal are for everyone because we are all dying. So it is not just for nurses or doctors or people dying, which is all of us, but it really is meant for anyone who wants to get comfortable through education about what dying is like to an ish, right? I mean, I really don't talk about like what dying is like from a car accident, right? It's more about like if you have some kind of terminal illness, learning about that kind of death. And same with the journal. So it's really for anyone who wants to increase their knowledge. So if it's mostly nurses who listen, I would say any nurse who is curious about where they want to start working, or if they want to switch into hospice, or if you're an ICU nurse,
right,
and you want to know more about death and dying. I mean, to me, this would have been invaluable when I was an ICU nurse. It would have blown my mind.
Yeah.
Because it blew my mind becoming a hospice nurse. I was like, what is this?
And I think it blows my mind because, like, no one talks about this.
No.
There's no educational workshops. There's not a lot of YouTube videos, not even a textbook.
My YouTube videos,
Hey, there you go.
Right?
You know, 4 million.
I mean, I know. I mean, yeah, that's the thing is that's why I started becoming so passionate about it because I was like, how have I been a nurse for almost a decade and I didn't know this stuff, right? Yeah. So in dying, I hate to keep saying dying is beautiful because I get the sadness around it.
I understand, yes. But I mean, life is sad in general. And,
yes.
You know, you have to enjoy the good times and the bad.
Yes. And the fact that like our bodies were literally physically built to do it was just so fascinating to me.
But I think that that's a beautiful part. I'm very spiritual on one side where I'm just like, you know what, you came to Earth to do a mission. And once you've done the mission, you know, it's been a good run. And when it's your time, you know.
To me, I feel like knowing the truth of your quote unquote fate, right? Let's say you have some terminal illness and you're at the end of this, right? No matter what you do, that's at the end. Wouldn't you want to know that? So if you have 6 months are left to live, wouldn't you want to know so you could live out the rest of your life?
Live your life.
And do what you want to do?
It's almost like if an oncologist, doctor, or provider would be like, hey, you have cancer, and they didn't tell you how long you had to live. I would want to know, like, hey, you have 6 months. I'm like, okay, I'm going to reorganize my life.
And this idea of people going, and providers, again, I never want to sound like I'm like calling people out, but here's what I'll say.
But it's the truth.
Here's what I'll say. People who say, we never really know.
Yeah.
I want to go, you kind of freaking do. If you are an oncologist who's been dealing with this type of cancer for 25 years and you know the treatment, you know where they're at, you kind of do.
You know the stats.
You know the stats. And yes, I do think if there is a standard treatment, you should do it, right? If there's a particular surgery plus chemo plus radiation is going to extend your life 7 years, yes, do it. But when the time keeps coming where you know as a provider, because you've seen this over and over and over again, hey, they are looking like they've got about 6 months left to live.
Yeah.
I think we need to be a little more blunt about that because all people hear when you say you have about 6 months left to live, but we could try this one treatment, maybe. They hear that we can try that one treatment, maybe.
Yeah.
And I don't blame you for saying that. I don't blame them for wanting that. But I think I just see so many people missing out on those last few months of life because no one's willing to really give it to them like that.
Yeah.
And like that is you have probably 6 months left to live no matter what we do. How do you want to live your life? And I think most people would say, at home with my family.
Yeah, it reminds me a lot of my grandma. She had pancreatic cancer, which is one of the worst cancers to have in terms of the duration of life. And I think they only gave her like less than a year. She lasted a little bit longer, but it was a lot easier transition. I think she was at home for majority of that time.
Yeah.
And my uncle's a doctor. Obviously, I'm a nurse. And it was a lot easier for us. But can you explain just in layman terms, what does a good death look like from a hospice perspective?
Okay, from a hospice perspective, yeah. So because what I was going to say was a good death is like whatever you as the person dying would want it to be. I don't want to say like, if you don't want a death at home surrounded by loved ones, then that wouldn't be a good death to you, right? So it is like whatever the person wants. But I think a good death for me as a hospice nurse is someone who is dying as they want to, right? So let's say they want to be home with loved ones. They have spoken honestly about how they feel about this, where they're at with the fact that they're dying, even if the truth is, I'm angry and I don't want to die. That will give you a better death. There is something about speaking the truth. So anyone who's willing to speak the truth of what's happening.
Just get off your chest. What's good, bad, or ugly?
Yes.
Would you say that that's what people fear the most about dying, or is it just being honest with themselves, honest with their family, or what do people fear the most
I think they just fear the unknown. I mean, death is like the ultimate unknown, right? So
yeah, you're right.
Most people fear that. They
fear itself.
Yeah. Fear dying because they don't know what it's going to be like, and hence why, as a hospice nurse, and again, it's a little easier for me because they know why I'm there.
Yeah,
right.
Of course, yeah.
So there's already this like preload.
Oh,
Yeah. I'm not the one breaking the news, right?
Yeah.
I would be, though. I would. That's so just so everyone knows. Like, if I had to, I would.
All right, let's be real. Nursing school, clinicals, even 12-hour shifts, they don't get easier. But the right scrubs, that makes all the difference. That's why I send students and nurses to Uniform Advantage. They've got everything you need all in one place. Scrubs that fit the way you want, shoes that you can actually stand in all day, especially when you go over 12-hour shifts, and all the tools that you'll ever need, like stethoscopes that doctors love to take, jackets that'll keep you warm, especially in those cold hospitals, and the accessories that make the grind a little bit smoother. So instead of bouncing around to a dozen websites, Uniform Advantage keeps it super simple, a one-stop shop with everything you need. And here's the best part. Prices that actually work for both the nursing student and the new graduate nurse. So head over to uniformadvantage.com and use the discount code SIMPLENURSING to take 15% off your next order. So don't wait. Your shift and your feet will thank you.
What I found was when I'd go speak to patients, right, and I would openly start talking to them about, like, here's what you can expect at the end of life. Here's what you can expect with your end of life journey, with your specific disease you have.
Wow. Is there like a step-by-step protocol that's generalized?
Yeah, that's generalized, yes. And I love talking about it, oddly enough. So I'm like a nurse who's like coming in there and being like, listen, I'm going to tell you all the things, because I know I would want to know all the things, right? And even with specific diseases, people generally die the same.
Yeah.
But specific diseases, you can kind of tell, you can expect this, you can expect this, you can expect this. And my point to saying all that is that helps alleviate some of the fear, because it takes out some of the unknown. Yes, some of the unknown.
So just explain, so if we were to put it down on a bullet point list, explaining the disease process, what's happening to the body.
Yep.
What's next? Is it like making, what would you say, communication with their loved ones?
Yes, and that's where
people doing, like, I don't know, getting their house in order?
yes. So I never hit them with that stuff.
Okay.
The first visit, where first it's about the disease process.
Okay.
Well, let's explain your disease process and what death and dying and how your body's going to help you die, right?
Wow.
Which is
Crazy to think.
in the last 6 months of life, you're likely going to be less social.
Right.
You're going to kind of like cocoon. Like, your body is going to make you be like, I'm going to be a little less active.
Right.
I'm not going to be as hungry or thirsty. I'm going to probably sleep a little more. I might be a little less social.
It's like Maslow's, you're focused on physiology.
Yes.
Okay.
So then your body will slowly just keep doing that more and more. Eating and drinking less. You do not feel hungry. Sleeping a lot more. Getting a little harder to do the everyday things, right? So you do lose independence. There is difficulty there, right? Because you're used to being able to do whatever you want to do, and you won't be able to do that anymore, which is hard. But that is the main things you're going to see. And I always tell people to focus on, like, if they're caring for their loved one who's dying, they should focus on, are they clean? Are they safe? And are they comfortable? And if they are, what are we going to do the rest of the day, right? Like that's it.
Yeah.
And then the person dying just focuses on how they feel and doing what they want. And if they're comfortable, like, okay, if they want to sleep, sleep. If they don't want to sleep, don't sleep. Whatever they want to do that day is what they should do.
Do you think this is the reason why people watch you a lot on social media? Is it family? Is it nurses? Is it both? Is
Oh my gosh.
education?
Right. The social media thing. First off, I was so surprised that it blew up. And it really did blow up like overnight. I had no, I didn't think about it. I didn't plan. You should see some of my first videos.
This came out of the, oh yeah.
My first videos are so bad. It's like barely, almost like in the middle of the night in my room being like, hey guys, like just me and my phone.
Yeah.
And how it happened was, after a few years of being a hospice nurse, again, I was super into it. A couple of my very good friends, their parents got sick and were dying. And I was sort of rattling off all the things I knew about death and dying to them. And they were like, how have we known you for so many years? And like, we didn't know that you knew this stuff. And it's because, like, at dinner parties, you say you're a hospice nurse, people in real life are like, oh, or
I
like,
want to talk to you about that.
I know, we don't want to talk about this. This is uncomfortable.
Mm-hmm.
So I just never assumed people would want to talk about it, right? But these two friends of mine were like, you got to do something with this. You need to like start talking about this. People need to know about this. And then I saw my nieces who were tweens and they were on TikTok. And I got on TikTok just to watch them do their dances, literally. Like, that's the only thing.
That's the reason you joined TikTok.
Yes, that's the reason I joined TikTok. And then once I started watching TikTok, I saw people like my age. I was almost 40 at the time, like talking about like space and gardening and stuff. I was like, oh my gosh, there's like people my age on here. So I recorded like 3 or 4 videos, again, in my bedroom, just being like, bada, 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 about death and dying. And the 4th one in, like, went viral. I had like 10,000 followers overnight, 100,000 followers in a month, 1 million in a year.
Oh my gardens. This is
Right?
crazy.
And then it went to Instagram, YouTube, Facebook, and then the book deal. So my whole point to saying all that is I think people do want to know. We always say we don't want to know or people don't want to talk about it. But I feel like my social media is evidence that this is something people want to talk about and learn about. And maybe because it's not real life, like I'm like a screen that they're watching, right? It may be a little easier to take in.
Yeah, maybe more palatable.
Yeah.
We're going to make you into a cartoon, which would be real easy. No, okay.
Oh my God.
How would they add?
Yeah.
No, but I think that the climate and the culture that we're in, we have such curiosity about everything. So it's natural, right? That we would naturally be curious about death. All right, let's move into some Q&As here from your followers. What do you do in the final days when the patient's pain is more difficult to manage?
Okay, so 2 things there. When someone's in their quote unquote final days, it doesn't necessarily mean they're going to be in more pain. So that's a big myth that like dying equals pain. The closer they are to death, they're going to need more meds because they're more in pain, right? So one, know that not everyone dying is going to be in pain, and not everyone getting closer to death will have pain increase.
Wow, because I always thought that pain increased as death was imminent.
Yeah.
Oh, interesting.
It can.
It
I mean,
can,
it
but it's
can
not
depending on the disease, but usually it's like if they've had pain all along the way and it's been getting worse and worse and worse and worse and worse, then maybe yes. But if it hasn't been, then it's not going to suddenly become a problem. The second, let's just say it is though. Okay, let's say it is. That's when the hospice company needs to step it up. And really, families and patients need to ask their hospice company prior to coming onto hospice, how do you manage difficult cases? Not everyone's going to need a couple drops of morphine. Some people are already going to come onto service with, fentanyl and Dilaudid and a bunch of things to manage pain, right? And if you're already coming on to hospice knowing you have a lot of pain, that hospice company needs to say to you, we can do CAD pumps, which is basically like sub-Q needles.
Okay.
We can access your central line or your port. We can they just need to have like a plan on what to do. If you already know, hey, I already have pain that's pretty complicated. What are you guys going to do when things get out of hand? And if they can't really answer, they give you a typical answer like, well, we have morphine. It's like, no, that's not they need to be and some hospices are better than others, obviously. Some are equipped with all the stuff and some aren't. So that's stuff you have to ask ahead of time.
I see. And who do you advocate to? Is it the provider? Is that the hospice company itself, or is it?
It's as if you're the person advocating or you're the nurse advocating, you need to talk to the doctor and you need to talk to the administrator.
Got it. Okay.
And sometimes there's nothing you can do, but sometimes you can be the very, very squeaky wheel. This is in my book.
Yeah.
there's times when I have had just had it, and don't yell, don't scream and yell at work. But every once in a while, I'm sure nurses understand where it's like you've hit your max and you're like, no one's listening to me.
Yeah.
I'm the person here. I'm the person watching this person suffer.
Yeah.
This is what they need.
This is my patient. I need to stand up for them.
Yes. And most of the time, hospice companies will eventually do it, but sometimes they're just not equipped to, right? So that's the stuff you have to kind of know if you're a patient or a family member, what the hospice company will and won't provide. As a hospice nurse, you want to work for a hospice company that is like an elevated one that can do steps if pain's not controlled.
Yeah. All right, so last and final question, but a big question here, especially for a lot of our newer nurses, or soon to be. How do you cope with compassion fatigue, and what the heck is compassion fatigue?
All right. Yes. I definitely have dealt with compassion fatigue where I feel detached, from my job. I don't feel, I don't know if I wouldn't say I didn't feel compassion for my patients and like who I was working with.
Lack of empathy, maybe?
But lack of empathy and like detached.
Yeah.
It was a little like robotish, right? Or like I used to always say like, oh, I'm dead inside.
What do you think are steps that led up to that?
Not listening to myself.
In terms of burnout? Or
Yeah, like not working in a place that was conducive to my mental health. I mean, some hospitals are better than others. It was really hard to take PTO. It was really looked down upon to like take a mental health day. I mean, never would you ever, right? Like
yeah.
if you were asked to stay over, you stayed over.
Mm.
You know, there was no like, there was no, I can't tonight. Never.
Wow.
So, and that was because of where I worked and because I was a new nurse and that was the culture of the unit, right?
Yeah.
And once I got older and wiser, right, and switched to hospice, there was still, when I was full time, there was still that like, you take the extra patient because if you don't, the patient will suffer. If you don't, this nurse has to do it. You know, so that's the culture of nursing, I feel like at times, right?
Yeah.
And what I've learned over the years is to be confident enough to say no and to work for companies and places where you can say no. One, that's why I'm a big union girl. Because when you're unionized, you can say no and they can't do anything about it. And I will say, you know, I have been the one to kind of like spearhead the culture in the unit. I would say no, and the people would come back and go, well, if you don't, then so and so has to do it. And then I'll say, okay, this is gonna sound bad, but I will go, okay,
Yeah.
then they can do it.
That's the number one rule of what is it called? Emergency medicine. Working on the ambulance as a paramedic. They said your number one thing is personal protection and personal safety.
Yes.
Because you don't want to have two patients.
All right.
You and now the patient.
Yes.
Because if you overload yourself.
And then it looks right. So then it creates this culture of like, well, what the heck? Julie didn't do it, so now I have to do it. But then they learn.
Yeah.
Then I say no.
Mm-hmm.
And guess whose problem it is? The administrator's problem. And then people go, but then the patient, right?
Well, we need more funding.
But we need
get more staff.
This doesn't need to fall on the back of me.
Yeah, exactly.
And this doesn't need to fall on the back of nurses. It is unfair. I agree. And patients shouldn't suffer. I agree. But we are just as important. And I have learned that. I am just as important as anybody else, including the patient. And in order for me to be a good nurse and to not have compassion fatigue and not have resentment for the person that I'm going to see that I didn't really want to go see because I didn't have the time or the space to do it.
Or the resources, yeah.
Or the resources. That person's suffering now too because now they're getting a nurse who's burnt out and has compassion fatigue, right? So it stops at us. And there's easier places to do it than, you know, like it's easier for me now because I'm older, I'm wiser, I've been doing it for long enough, and I'm a unionized nurse in California, period.
Yeah.
Right? But like...
I mean, to that point, it's like you're only one person.
Yes. Yes.
There's always going to be the next patient.
Yes.
You can't do 100. And if you do 100, you can't do 200.
Right.
And if you do 200, you can't do 500.
Yes.
I worked in 9 different emergency rooms, some bigger than others. And think about it. If we had 10 beds, we had 10 beds.
Yep.
We can make maybe 3, but you can't make 100.
No. And you're allowed to, and it's going to feel like you can't say no. It is. It's going to feel like you need to say no. There's always something else. And there probably are certain cultures where like you can't actually say no, right?
Yeah, but
you really
time
can't.
and place, yeah.
Right. But generally speaking, that's what I implore everyone to do is to get confident enough to go, I can't. You know, no, I can't. And guess what they'll listen to? It's unsafe. This is unsafe.
That's the number one rule on Netflix.
This is unsafe. I don't feel comfortable with this. This is unsafe.
Protect your license, yes.
Yeah.
And protect your patients and protect yourself.
Yes. Yes, yes, yes. And that's the biggest thing I've learned, and I'm so grateful I learned it, and I'll preach it, if you couldn't tell, till high heaven.
I love it. I love it. What's one myth about hospice nursing that you wish every nurse or really the general public understood?
Oh, man.
There's a lot.
There's so many. One myth about hospice nursing. I think if you're a nurse watching this, one myth is that like you'll lose all your skills and it's like what you should do when you're about to retire. It's definitely a different skill set, but that's not the reality. You should be an experienced nurse to be an hospice nurse.
Like
because
accumulation of all your skills.
Yes, because you're alone. You go to people's homes. So you're working out of your car. You have to make decisions on your own. Of course, you call the doctor and get the orders, right? But like you are the person that has to know what the heck is going on. So for me, like the ICU background was so good because I kind of knew what we would do if they weren't on hospice, right? Or if like they weren't dying, I would know. So I knew that side of it. So then I could be, I feel like it made me a really good hospice nurse. So I think you should have experience before you go into hospice.
Oh, for sure. It sounds like it.
Yeah.
So what's the big difference between palliative care and hospice?
Palliative care is a symptom management program.
Okay.
Generally speaking. Okay, I'm being very general here,
Yeah,
but
generally.
only because it would take a long time to
Your
actually
whole
explain the both,
yeah.
right? Explain both of them. But basically, palliative care is a symptom management program. I think anyone with like a life-limiting illness should be on palliative care.
What's an example?
Like if you got diagnosed with cancer and you are receiving chemo, radiation, and you had a surgery, right? I think palliative care would be a great factor in there because they would help with the symptoms of the disease or the symptoms of the treatment for the disease, right? So someone who's like in a lot of pain or has a lot of nausea or vomiting, they could be on palliative care and they would kind of look at them as a whole and help manage those symptoms so they don't spend a million hours in the ER. Right?
Oh, that would be the worst. Like
Yeah.
I see it a lot.
You see it all the time. And where hospice is truly end of life, you have to have a doctor say you have less than 6 months to live.
Is it the 6-month window or more?
It's 6-month window.
Okay.
Now you can live longer than 6 months.
Of
People
course.
often do, and you can stay on hospice. But technically, you have to prove that you have less than 6 months to live. And the other big thing is that hospice is always funded by Medicare.
Really?
Yes. Unless it's a hospice that somehow like collects donations and like they don't work off Medicare, but very few and far between do that. Most of them are all Medicare driven, which means Medicare is our boss, which also means all hospices should be operating the same.
Got it. Like standard.
Yeah,
so
standard of care. Whereas palliative is a little different. It depends on what hospital you're at or who is doing the palliative care.
So big question here. Would you recommend that a new grad right out the gate go into hospice immediately?
Here's what I'll say. I never want to say no because I get if you have a real passion for it, I want people to do what they're passionate about. If you are a new grad and you're thinking about starting off right into hospice, I would always, with like 100% certainty, you have to do this. Do an inpatient hospice care. So there are inpatient hospices where like it's like a hospice home where there's 10 patients at a time and they're all hospice patients. Okay, so you're still working at a place with other hospice nurses, doctors there, so you can hear them talking about things. You can see what they're all doing. So you can learn on the job that way. Because I think when you're a new nurse and new grad, learning on the job, I know for me, the first 6 months of being an ICU nurse, I dreamt every single night of like beeping and like things going on.
Yeah.
And I had a preceptor who followed me around for 6 months, right? And you really, really need that. And as a new hospice nurse, if you were going in people's homes,
You're alone all the time?
you're alone all the time. And you would really only get like a couple months maybe
With the preceptor.
with a
training.
preceptor.
Yeah.
So you really need to know your stuff
Crazy.
to do it. So if you're going to do that, I think it's doable, but I would do an inpatient hospice.
That makes a lot of sense. I think that humans learn the best by modeling behavior.
Yes.
I can see with my brother's little kids, the toddlers, that everything you say is like little parrots. But I think that's the same way as learning anything new, like a new grad. So,
and you have to be comfortable with seeing someone die, right?
Yeah,
like,
that's
and
the
if
way.
you're not used to that, you could be a little bit like, is this right?
Jarring.
Is this okay? Right?
Yeah.
But and so you'd have to. That's why I think it's important to have experience. Now, if you already have a couple years experience and you're like, I'm sick of this, nurses, are you guys listening to me?
Listen up.
Learn from me. Like, you are a nurse, you are needed everywhere. Don't be afraid to make changes. Like, I was so afraid to leave the ICU, even though it was like literally killing me. It felt like it was like killing my soul. I hated it so much. I still stayed for like years because
Really?
I
That
was
sounds like a
afraid.
bad relationship.
I know, right? So don't do what I did. Move around. Like, you can do it, move around. So if you have been a nurse in med surg or ICU or the ER for a couple of years and you're thinking maybe I want to transition, hospice is a beautiful place to go. And definitely a couple of years of experience somewhere else is definitely enough. And you just got to take that plunge. That's all I did. I literally applied for a job that said must have hospice nurse experience. I did not. And I applied, and I basically, like, in the interview, like, begged them. I was like,
my God.
I know I don't have experience, but I really want to do this, blah, blah, blah. And they gave it to me, you know?
I mean, new grad nurses, listen up. You apply for everything, even if they say you need experience.
Yeah. And I always recommend nurses doing like agency nursing, travel nursing. I mean, there's just ways to nurse. Like I always say, like work smarter, not harder. I mean, I put in a bunch of like hard work in those first couple years. And then like after that, I was like, how can I help people, but also make money, but also have good work-life balance? And you can make nursing work for you. You can find your niche to have the life you want and the job you want. I mean, I truly am like the happiest I've ever been. And the whole Hospice Nurse Julie thing has been amazing and like icing on the cake. But even before that, becoming a per diem nurse where I could like make my own hours, do what I want, but still nurse, still have a good life. It's been so beautiful. And like any nurse could have that. You know, you just got to figure out what you want.
And that's the beauty of nursing. You can do almost anything with any department. I was supposed to be a physician assistant before, or PA. And sometimes you're just specialized into one area and you can't move around as much. So nursing is amazing in terms of adaptability. All right, guys, that wraps up our podcast for today with Nurse Julie here. Her book, Nothing to Fear, you guys can get on Amazon. You also can get it on Barnes & Noble's, Walmart, but I think Amazon's probably the easiest.
Probably the easiest.
Are you going to come out, side note, are you going to come out with an audiobook?
It's already out, and I recorded it. It's my voice.
I love audiobooks.
Mm-hmm.
If you can see it from my face. Where can our viewers, listeners find you on social media?
You can find me anywhere you get social media at Hospice Nurse Julie.
I love it. Well, thanks so much for coming on the show. I can't wait till the next episode, or hopefully we're doing this again, and your next book. So again, thanks so much for watching and listening to Bedpan Banter. And as always, don't let the bedpans bite. Woo-wee!